First, I do want to stress the fact that this is a new clinical categorization of acute pulmonary embolism, and we're using this to help guide clinicians who are managing patients with acute pulmonary embolism in how they can manage these patients most effectively and most safely. So we have the five clinical categories, and I'm happy to elucidate them a little bit now, if you would like. Um, we've lettered them A, B, C, D, and E. And let me just remind everyone listening to this that this is not the first time clinical categorization has been proposed for managing acute pulmonary embolism. The American Heart Association did over a decade ago, and the European Society of Cardiology did more recently. But this is a refinement of what we've seen previously. Based on where we are in terms of assessing pulmonary embolism and the options we have for therapeutic strategies. So the five categories are A, B, C, D, and E. I'll just briefly summarize what each of them are about. A are those who are least sick. These would typically be patients in whom a pulmonary embolism was picked up incidentally, perhaps when someone has had a chest CT scan for another reason, like modern lung cancer, and a pulmonary embolism is seen, but they're asymptomatic. Those patients, if they're otherwise feeling well, do not have to stay in the emergency room, or they can be discharged from the emergency room. They don't have to be hospitalized. The hospitalization would really be predicated on other problems that they were having. Uh, Category B is really patients who are mildly symptomatic and when doing a clinical severity assessment with one of the tools that are available, are deemed to have good prognosis. In other words, they have a low clinical severity, and we anticipate that they would do well. And they can typically be discharged home from the emergency department and managed, with anticoagulants in the outpatient setting. Category C are patients who are symptomatic, perhaps more than category B, but they rank higher on the clinical severity score, whichever tool is being used. So there is concerns about their initial prognosis. And in general, we would be hospitalizing those patients. And we've divided category C into really three components: C1, C2, C3. So C1 are symptomatic patients who score at a higher level on the clinical severity assessment, but don't have other concerning issues that would indicate a less good prognosis. So their cardiac enzymes are normal, that's troponin and BNP, and their echocardiogram does not show any evidence of right ventricular dysfunction. C2, those individuals, again, have symptoms. They've scored higher in the clinical severity score, and their cardiac enzymes are elevated, either troponin or BNP or proBNP. In category C3, these are individuals who have also demonstrated evidence of right ventricular dysfunction, uh, typically by echocardiography. Category D, we're getting to fairly sick patients now. We have two categories, subcategories within that. D1 are those who've had transient hypotension, so their blood pressure has dropped in a worrisome manner. Fortunately, has come back, but we know that there are kind of incipient cardiopulmonary failure. And D2 are those who have normotensive cardiogenic shock. So they're quite ill. And by measures of shock, such as lactic acid, uh, even though they're normotensive, we know their organs are not being perfused adequately. And the sickest category is E, which we've also divided into E1 and E2. E1 would be people with persistent hypertension, cardiogenic shock, and E2 would be people who have really had a cardiac arrest as a consequence of their pulmonary embolism. So that's the categorization we're using, and based on where people fall in that, it may help in decisions of placement in the hospital, where they can be discharged home from the emergency room. The type of therapy they should receive, either just anticoagulants or for the sickest of them, particularly D1, D2, E1, whether they would be an appropriate candidate for advanced therapies such as systemic thrombolysis, catheter-based thrombectomy, or surgical embolectomy. So the second part of your question, or the related part, is what do we do in resource-limited situations? And it really depends on the severity of illness and the resources that are available. So, in most circumstances, the diagnosis of acute pulmonary embolism can be made in almost every emergency room. Uh, so if there's a significantly high clinical suspicion, the D dimer level is elevated, and the clinician is concerned about pulmonary embolism, CT scanners are usually available near most emergency rooms. So that should be available and should be used in most patients. But then when you get to a situation where uh, the patient's fairly ill and the resources are limited, we did make recommendations on transfers to hospitals with adequate resources. Most places in the, I'll say many places in the community and certainly in rural areas may not have access to advanced interventions such as catheter-based treatments or surgical embolectomy. You know, we would prefer to see those patients transferred as long as they're medically stable and can withstand a transfer. Well, great question, great question. And our writing committee thought long and hard about each of these, and we do have recommendations uh, in these acute pulmonary embolism guidelines about managing patients with anticoagulants, which anticoagulant to use, which anticoagulants not to use, and that has to deal with people who are overweight and obese. We have recommendations regarding patients who have renal failure. We have recommendations for patients who have hepatic disease, recommendations for women who are pregnant and breastfeeding, and they're not all the same. They're actually tailored for each of those conditions. Yeah, well, it's clearly not all institutions are going to have these teams. I mean, larger medical centers, academic institutions uh, have specialists who manage patients with pulmonary embolism. And a pulmonary embolism response team can include a number of different specialty areas uh, who work together closely to make decisions on the best management for these patients. And this will not be an inclusive list, but this will be many of the people involved. We have a whole figure in there that names the many people who are involved in the interdisciplinary, multidisciplinary care of these patients, whether it's just the emergency uh, physician, cardiologist, pulmonologist, hematologist, cardiac surgeons, interventional cardiologists, and the list is longer than that. And it really depends on the hospital who's getting together to form this pulmonary embolism response team. So first, I would say if the institution has the personnel available to put a pulmonary embolism response team together, we recommend that because it has been shown to certainly decrease hospitalization time and may have beneficial effects on cardiovascular outcomes. So we encourage that. And we would encourage once a decision is made to certainly bring a patient into the hospital. So either the emergency department or once they're in a hospital room, uh, let the pulmonary embolism response team gather together and help the primary team in managing the patients. But clearly, there are many, many, many hospitals that don't have all these resources, and so we have the guidelines. We have recommendations that emergency departments and hospitalists and others should be familiar with to help guide their management. So there won't always be a pulmonary response team, and in many hospitals there cannot be because they just don't have the personnel. So the in the ideal circumstance you put one together, but um, we recognizes that we recognize that there are smaller places that are resource limited that won't have that. Well, that's a great question. At the end of the guideline, There's a section called gaps, not gaps and opportunities, if you will. Uh, this field is moving very fast. There's been a lot of interest. There's been an encouraging amount of research, ranging from fundamental research, but also through clinical trials, outcomes research. So it's a fast-paced field, as many other fields in the general area of cardiovascular medicine, cardiopulmonary embolism, pulmonary medicine uh, exist. Um, so uh, there are things we need to know. One area is advanced interventions. And you'll see we don't have any class one recommendations on advanced interventions. And why is that? Because we don't have enough clinical trials. There'll be a few reporting out very shortly on outcomes, looking at comparative approaches to patients who have really uh, advanced severity pulmonary emboli. So what I would call category D1, D2, E1. What's the best approach? So studies will be coming out, but whether uh, what we do know is that many advanced interventions do something in the short term, right? They improve uh, hemodynamics quickly. They improve right ventricular function more quickly than maybe anticoagulant therapy alone. But we don't really know what the long-term outcomes are. So let's see what these trials show. Um, uh, if they do show that there's improvement in outcomes with an advanced intervention, then when we do the iterative guidelines, the update, then we'll be able to assess those studies and change the classification of recommendation. But right now, we don't have anything in the class one category, so we need research in that area, certainly. Other things you already mentioned previously is what do we do in certain populations? We don't have dedicated trials in obese people. We make inferences based on large trials in which obese people were included. Uh, but we don't have targeted trials for them or some of the other situations, the comorbid conditions that you mentioned, whether it's renal failure or hepatic failure. So we need to look into that as well. We need trials and implementation, implementation science. How are we going to bring these guidelines to the folks that are going to be using them and help them understand them and use them so that their patients have the best outcomes. So these are areas that are certainly important, open to research opportunity. I would encourage individuals interested in this area to start looking into this. We do need more research. What's not in the guidelines, but which we need to cover, is to increase awareness of pulmonary embolism, particularly among the public. When people are not aware that the symptoms they have may be a pulmonary embolism, uh, they're not going to do anything about it. So when people get these symptoms, they have to seek care and seek care urgently so that the diagnosis can be made promptly and appropriate treatments can be undertaken promptly. So I think public education awareness really needs to be at the forefront, like we've done in many, many other areas like heart attack or stroke. I think people need to understand what pulmonary embolism is, what the symptoms may be, and that they do need to seek care. So I think that is really important. And then we really need to make sure that everyone who's taking care of patients, all the clinicians, all the teams that would typically be dealing with patients with pulmonary embolism, are familiar with these guidelines so that they can use the information, um, understand the evidence, and make decisions in part based on the recommendations that we've put forward.